Thank you for your kind invitation to talk about this very interesting topic that is ultrasound guided fine needle aspiration biopsy in skin lesions. My name is Fernando Alfageme, I'm a dermatologist from Madrid, and in this presentation, both Dr. Castro Rostan and Laura Nájera, our dermatologists, have collaborated. And it's very important because the collaboration of the team is very important to reach a correct diagnosis. Both clinical, sonographical, and cytological aspects have to be taken into consideration to reach a correct diagnosis. These are the contents of our presentation. Why ultrasound in dermatology? Why this fine needle aspiration? The technical requirements and processing of samples, the cytological aspects of most common skin tumors, and finally, we will share with you some clinical cases we have been doing with this technique. Why fine needle aspiration in dermatology? As we've seen, the ultrasonography knowledge has been increasing along these years. We have more knowledge now than before, but despite this fact, there are sonographic and specific lesions that require a histological diagnosis yet. However, we have the previous experience in some other specialties in which fine needle aspiration with ultrasound guidance is very common. This is a common example of why ultrasound guided fine needle aspiration is relevant, could be relevant. This is a mass in the shoulder or the foot, and we see here this tumor, this vascularized tumor, deep tumor with hard areas that it's very difficult to assess from the only from the sonographic point of view, on the clinical point of view. We would need a fine needle aspiration, and in these kind of cases where clinical diagnosis is not clear and sonographic diagnosis is not clear, fine needle aspiration has a role, because a biopsy, an open biopsy, would have morbidity, for example, in this case, because the patient couldn't walk. Fine needle aspiration in dermatology is not new. Most publications have been made by pathologists blindly, and they refer an accurate diagnosis in 42%, and a sensitivity to differentiate between benign and malignant lesions of 80%. However, as I've told you, if we add together the clinical knowledge, the sonographic knowledge, and the cytological knowledge, I think that we can improve these yields. The pros of this fine needle aspiration biopsy is that the speed is immediate, the minimum discomfort, and the few complications we have. The cons, that we are dealing with cytological diagnosis, that is harder than histological diagnosis, and the possibility of false negatives when we do it in a blind way. In the case of ultrasound guided, we reduce this number of false negatives. We have two kinds of techniques. We would have the short axis technique and the long axis technique. In the short axis technique, we would have a perpendicular to the lesion approach, and in the long axis we would have a longitudinal approach to the lesion. These two approaches have their advantages. In the short axis approach, the most important advantage is the easy way we can do this kind of fine needle aspiration, that is very easy for beginners and for big superficial lesions. However, it has less control. However, we have the advantages of short axis would be that is easier. It's a technique mainly for beginners, for big superficial lesions. The main disadvantage is there's less control of the needle tip. Regarding long axis, the advantage is total control of needle, and that is good for small and deep lesions, so more difficult to locate. The main disadvantage, however, is that it's technically more difficult to perform. This is an example of a short axis puncture or fine needle aspiration. Which materials are we using? We are using this kind of pistol, that is this Cameco pistol, and we use this kind of needles. For very solid or fibrous lesion, we would have this kind of thicker needles, and finer for this more cystic or purulence. Then the dependent on this. Which are the materials that we need? We would need a pistol to hold the aspiration. Which materials do we need? We would need a pistol to make a kind of negative pressure as for aspiration, and needles. These needles, depending on what we are aspirating, whether it is solid, fibrous, or cystic or purulent, we would use thinner or thicker needles. The technique is relevant. We have to insert the needle perpendicular or parallel to the skin, depending of the approach. We aspirate as much as possible when we are in the lesion. We make two kinds of movements, in and out and rotational, and we release the plunger to remove the needle always when it has returned to original position. This is very important. We do it inside the lesion. How is sample processing? Sample processing needs this kind of materials, not very expensive. You have here the pistol, this kind of syringes, these needles, and this is a tinction. We lay this on the slide and we extend it, and we air dry or alcohol dry, depending on the technique we are doing this extension. We also prepare cell blocks for near histologic diagnosis, as you will see in our cases. Then we will process it with two kinds of procedures, with May-Grunwald Kimsa, or what we call DIF-Quick, and Papanicula. These techniques have differences. The May-Grunwald is used to have a very quick staining technique, with the main disadvantage of less cytological details, and Papanicula that it's a bit more slow, with the main disadvantage of this, of better cytological details and real cell size. Then we do both to go for a diagnosis of most of our lesions. Here you can see the differences between a DIF-Quick with less details and best detail of Papanicula comparing to this and this. We can also do complementary techniques such as immunochemistry and molecular biology that we will do in the direct extension, the liquid cytology, and the cell blocks. The cell blocks are performed with coagulation of thrombin. With this coagulation of thrombin of the cells, we are able to process it as a normal pathology immunohistochemistry sample. We are going to deal with the cytology of most common skin lesions. First, it would be the cytology of lipoma with adipocytes with clearly marginated nuclei, dermatofibroma with these spindle cell extensions that can be further studied with immunochemistry, positive for X11 for factor 12. Pilomatricoma with these small, very roundish cells. Cylindroma. You see here that the cells tend to reconstruct the 3D dimension of the specimen. Then this aggregation of cells is also diagnostic of some tumors. like in this case too, in cream puroma. In basal cell carcinoma, you can also see these small, very small basaloid cells, squamous cell carcinoma, with this Papanicolaou staining for keratin, the big cells of melanoma, some of them staining with melanin, and Merkel cell carcinoma with all this very similar cell, very roundish, and that tends to make this kind of blocks, as I told you before, that also mark positively for cytokeratin 20. And now we are going to go with some clinical cases. Clinical case number 1 is a patient with a previous surgery in the temporal area that with a recent growth of this nodule, you can see here. And when we go for the ultrasound, we see some concerning mass that is invading the bone that maybe has something to do with the previous surgery. But there's no other way to know about this but an open biopsy or in this case a fine needle aspiration biopsy. In this case, the least aggressive alternative is that. These are the nuclei with quick big cells, epithelioid cells that correspond to squamous cell carcinoma. This is the Papanicolaou of this case. This is the block of this case, as you see, and as I've told you before. With the block, you can kind of reconstruct the microstructure of the tumor. This would be a little piece of this. Then, with a very, very small amount of cells, you can reconstruct some kind of pseudo architecture that is helpful for diagnosis. In case number 2, this is a patient with a previous squamous cell carcinoma that has developed this nodule, retroauricular nodule. This is a suspicious node that was biopsied with fine needle aspiration biopsy, and this was the reactive pattern that we saw, confirming the reactivity of this lymphadenopathy. This is a case of a young man with a previous antecedent of breast carcinoma, and with this architecture and ultrasound, you can think of pilomatricoma. That would be our diagnosis. But with this previous antecedent on this patient, we need some more to make it sure. In this case, we see this kind of cells, small, very small cells that tend to aggregate in this way, making this kind of phantom of goat cells. It corresponds to pilomatricoma. This is the histopathology sample, and this is the pilomatricoma cell block. As you see, it's very similar. This is a little piece of this, but this is reconstructed with the coagulation with thrombin with a very, very small number of cells. I think it is amazing. And you can here work with immunohistochemistry that can allow you to widen your diagnostic capability. In this case, we went for the catenins and the negativity for BRBP4, showing that this was really a pilomatricoma instead of basal cell carcinoma. As you see, ultrasound fine needle aspiration biopsy is necessary in some cases when ultrasound is not clear. And this ultrasound fine needle aspiration biopsy allows a precise tisular sampling of this kind of tumors. Moreover, when they are subcutaneous, access is not easy, or surgical access is not easy. Ultrasound fine needle aspiration biopsy in dermatology needs close collaboration of both clinician and pathologist. That is clear. The first image of the team. If we don't have a team, or we do not team with our pathologist to select the appropriate sample and make a later interpretation of cells and images of ultrasound, it's quite difficult. Then a collaborative multidisciplinary approach is very necessary. If the pathologist on his sound or the dermatologist or clinician on his sound tries to do it, it's quite difficult to reach a quality diagnosis. Thank you very much for your attention.